between upper and lower respiratory tract infections. Today we have Dr. K.K. Chopra with us. He's a renowned pulmonologist, director of New Delhi TB Center, managing TB program for many years. We are waiting for others to join. Meanwhile, there is a link in the chat box for the pre-test. Kindly fill up the pre-test. As you know, one of the requirement for certification is that both the pre and post-test should be attempted. Don't worry about the scores. The aim is to engage you, make you think about this. Otherwise, just attempting this is important. Don't worry about the correctness or because online programs have their own limitations. So we want to overcome this limitation by actively engaging you. And also it helps us in understanding your viewpoint and the problems that or the clinical variation that we see in clinical practice becomes evident when we do this pre and post test. I think Siddhi, you can call them if he's around. We can start. हाँ सर आ गए तो शुरू करा दो.
Good afternoon, Madam. Good afternoon. Good afternoon, sir. Chopra, sir.
Good afternoon, sir. Good afternoon.
Yes, sir. Good afternoon, all. We, on behalf of NHSRC and DSPRUD, we welcome you all for the 16th session on STG webinar on managing the respiratory infections. We have already the pre-test links have been shared. You can attempt the pre-test and post-test to receive the certificate of participation. Now I request Dr. J.N. Srivastava, sir, Advisor, Quality and Patient Safety Division, NHSRC, to welcome and address all of you, and to set the objective and to share the objectives of this session. Over to you, sir.
Thank you, Siddhi, and I hope I am audible.
Yes, sir, you are audible, sir.
Thank you. Thanks so much. So at the outset, we are extremely grateful to Professor Chopra for having taken time out of his busy schedule to talk to us. And of course, I extend a very warm welcome to now a dear colleague and crusader, Professor Sangeeta Sharma, who had been, in fact, singularly leading these efforts for last one year plus. And all the participants, those of you who have joined from the states, from the central government institutions, and from other hospitals and healthcare facilities. Why this series was started? That most of us in the clinical practice all alone, and in the day-to-day nitty-gritty, day-to-day managing the hospital, managing the patients, we lose a touch. We don't keep abreast that what are the recent developments, how in an ideal scenario, a particular patient, a particular clinical condition needs to be managed. And it becomes more challenging when I look at the district hospital or CHCs, even in the primary health center, where very often the doctors and the physicians, they are all alone. And with this background, I mean, one side when we are endeavoring to improve the quality of care, and the quality of care, I realize that waiting time, ambience is important, but equally or perhaps more important is the clinical care which a patient receives. And I mean, whether it is the Apex Hospital in a best of the corporate setup, or even in the government setup, we often find, all of us must have experienced, that the prescriptions which are getting generated are not in sync with the clinical evidences, not in sync with the teaching. And in this direction, this is a small beginning, which in fact we had taken some time back, and the response had been overwhelming. And of course, we all know that Delhi Society for Promotion of Rational Use of Drugs has been leading these efforts in the country, in the different academic institutions, and all around working with the state governments for strengthening the clinical practices. And today's topic is very contemporary, or if I may add, a bit delayed, because the winter has already set in. And we all know, those of us who are in the northern India, not only Delhi, but even the places like Bombay, and every place is getting affected. Other than the infections, pollution is taking its own toll. And all of us are vulnerable. And it will be, since we have the eminent faculty, Professor Chopra and Professor Sangeeta Sharma, to talk on the clinical dimensions, but we all must have experienced that how much prone we have become to the respiratory problems, and which got in fact further manifested, and it became further glaring during the COVID time, which the country had to undergo for almost around 3 years or so. So without much ado, I will stop over here and request Professor Sangeeta Sharma to start the session. There are two sessions which are lined up, and one is that challenges in managing the respiratory infection, and Professor K.K. Chopra will talk holistically about that what should be our approach for managing the respiratory care. So once again, we are extremely grateful to both of you for for being with us and taking this initiative forward. Thank you very much. Our ED has conveyed his best wishes. Today he had to leave for the Jodhpur. Some urgent commitment has come up. So he had just texted me about 15 minutes back that he will not be able to join. So his best wishes are there, and we have his kind patronages and support for this initiative. Thank you very much.
Ma'am, you are not audible.
Okay, sorry. I started talking. Good afternoon, sir. Thank you for to NHSRC for continuously providing support for this endeavor. This is a broad, you can consider this endeavor as to implement the standard treatment guideline concept in clinical practice. And today we have approach to managing respiratory disease, this as the topic. Sir, आज मैंने थोड़ा सा reverse किया है sequence. First, Dr. Kamal Chopra will be talking about it. Then, from standard treatment guideline perspective, from the programmatic point of view, how can we reduce the clinical variation, which is many a time inappropriate in clinical setting. So I'll be talking about that part later. So I have changed the, because otherwise it becomes monotonous for the returning participants, those who attend all the sessions. Siddhi, can you introduce Dr. Kamal Chopra, and then we can start with the session.
Thank you, ma'am.
Before, just a minute, Siddhi, one request to all the participants. We have more than 75 people in the room, but I have got pre-test filled only by a few of you. So kindly attempt, doing this also, because this is one of the requirements. Otherwise, then, we'll have difficulty in issuing the certificate. So before we start, just spend a moment on this. These are all clinically relevant questions that we bring it out to you, so which make you think about it. Don't worry about the scores. We are not looking at the scores at all. We are just looking at it that whether we are making it an attempt to understand the dilemmas, the ground level situations, the subtle nuances when it happens and it leads to inappropriate variation, and when we deviate from the standard treatment guidelines. This is just to understand that. Kindly just, Dr. Chopra, can we wait a few minutes so that they can
Yes,
do
yes,
it?
sir. Please, please,
Yeah.
please. That will be helpful for the participants.
Yeah, because you will also understand,
right.
because we will make an attempt to address all these questions during presentation.
Sure, ma'am.
So,
Sure.
yeah.
Thank you, ma'am.
Madam, you are muted.
Okay, पता नहीं वो क्यों बार-बार म्यूट हो रहा है अपने आप ही. Anyway, I hope you are all doing it. There is no problem. You have access to the form. Siddhi is putting the link in the chat box. You've all been able to open it. Hurry up, please. Certificate nahi milega. If you don't attempt both pre and post test, don't worry about the scores. Nobody is looking at the scores, but we want to see the scenario. What is it? Where is it? Where the gap is? Is it the knowledge, or is it the just the question of practice, or is it the non-availability of the guidance? What is it that is leading to the inappropriate variation? Don't wait for the session to start. I think some people wait कि session में answer मिल जाएगा. थोड़ा हमें भी motivation मिलता है ना. If post seminar scores improve, so we also feel good about it. All the trouble taken, the amount of effort made was worth it. अभी नहीं कर रहे हैं क्या? 38. ठीक है. Shall we start? Only 30.
Yes, ma'am. Good afternoon, sir. We welcome Dr. K.K. Chopra, sir. He's currently director at New Delhi TV Center, and also his state TB training and demonstration. He's associate executive director at Indian JI of Tuberculosis. Sir has more than 34 years of experience in his field and more than 150 publications. Currently, sir is also a member of Central Committee for TB Association of India, member of national and state level committees of TB control and monitoring. Sir holds prestigious awards like PRJ Gandharam Endowment Oration Award, TB Association of India Oration Award, Charu Chanchal Das Memorial Award by TB Association of India, late Dr. and Mrs. R. Krishna Delhi TB Association Award, and Dr. Satyavedam and Dr. S. John David Memorial Oration Award by Andhra TV Association. Also, sir is Chairman Ethical Committee of NITRD and RBI BPMT, President of NatCon 2019, Facilitator for National and State Level Trainings, Chairman of Ethical Committee of NITRD Delhi and RBI PMT Delhi. We welcome you, sir, and over to you, sir.
Thank you for the introduction. First of all, I'm thankful to Srivastava sir, Sangeeta ma'am, and Dr. Renu for inviting me for this important session and this important clinical series, which may be very helpful to the physicians working in the field. So, topic allotted to me, managing respiratory diseases. Am I audible, ma'am?
Yes, yes, sir.
Okay. As Dr. Sangeeta ma'am mentioned that this will be in two forms. First, I will be tackling about its clinical and etiological points and manifestations, and a bit about the treatment. And Dr. Sangeeta will be delivering a lecture on this, using optimum use of antibiotics and what are the clinical guidelines to be practiced in the field. So I will keep my lecture to very simple, keeping in view that most of the doctors are from the field side, not from the academic institutes. So how we can tackle these respiratory diseases in the field, where sometimes investigations available are very sparse. Patient has to refer to other places to get investigations done. So how is the approach to managing a patient if he comes with the respiratory disease? Please, in between, if you have got any question, you can write in chat box or you can raise your hand so that we can discuss in between, and it should not remain monotonous from one side. Okay, so diseases of the respiratory tract comprise of airways and lungs, and it is divided into upper airways and lower airways. In today's session, we will be focusing more on the lower airways and especially pneumonia and community acquired pneumonia. As Dr. Srivastava said, that this is a time where we get many such cases because of the weather condition and pollution. So it can be divided into upper ways, which starts from nostrils to larynx, lower airways, larynx to alveoli. So diseases of respiratory can be, most common they are infection. There could be inflammation and environmental factor, which includes first of all pollution, which is very common these days, then smoking and industrial smoke also. Now, evaluation or management of respiratory tract requires, there should be comprehensive approach. It's not that we just take history and make diagnosis. It requires proper history taking, even past history. And secondly, some condition which predispose us to the respiratory tract, then proper clinical examination, because many finding can be in respiratory tract is the one system where that system can be examined by stethoscope and our physical examination, we can get many findings and reach up to some conclusion. So proper clinical examination is very important. Of course, investigations. Now there have been number of investigations. There has been revolution in getting investigation, like now ultrasound, CT scan, EBUS. Many newer investigations have come, which make our job simple. So various common respiratory diseases, we can group it as obstructive diseases. COPD and asthma is very common. Then comes the restrictive lung diseases, interstitial lung disease, chest wall disorders are there. Infectious respiratory tract, viral infections are very common in respiratory tract. Then bacterial and fungal and rarely protozoal infection also. Vascular diseases are common, not so common, but they are also encountered in clinical practices, difficult to diagnose many a times, like pulmonary embolism, very acute severe condition, pulmonary hypertension, aneurysm, which can rupture at any time, neoplastic lung diseases, especially in old age patients, lung cancer, and mesothelioma. Autoimmune diseases like SLE, rheumatoid lung disease, environmental occupational lung disease, almost all the many industries like asbestos, coal, workers that lead to silicosis or pneumoconiosis because of any dust inhalation. Hypersensitive pneumonitis is another environmental lung disease. Congenital diseases, cystic fibrosis and congenital lung formation. Sleep-related breathing disorders, which are very common nowadays. Many physicians are working on this. Obstructive sleep apnea and central sleep apnea. Traumatic lung injuries can be in any trauma leading to chest trauma, which leads to pneumothorax, hemothorax, or maybe some foreign body inspiration also. When we come to the management of respiratory tract, our approach is just like that in this sequence. Proper history taking of symptoms as well as comorbidities, because comorbidities tell us that patient may be prone to such type of infection because immunity is decreased in many comorbidities. Field examination is important, not only of respiratory tract, general physical examination also important because patient may manifest general conditions. Then based on this physical examination and history taking, we can reach up to some provisional diagnosis, or we can keep in mind different differential diagnosis, and with the help of diagnostic tests available, we can reach up to the final diagnosis and start the treatment specific to the disease which we diagnose. So regarding history taking, we should ask the symptoms which patient tells to us. Then we can objectively also ask them what has been the onset, duration and progress of the symptom. This only one question can lead us to some diagnostic problem what we are facing with. Then usual symptoms and called in respiratory disease are cough, sputum production, breathlessness, hemoptysis, chest pain and fever. And every symptom has got some typical findings depending on the disease. Like if we ask for sputum production, color of the sputum leads us to which bacterial or viral infection is there, can suggest us. If cough is dry or productive, we can see some differential diagnosis. Severity, there are different methods of grading the severity of breathlessness. Hemoptysis, how much is the severity, how many are episodes. Fever, pattern of fever leads to some diagnosis, like typical in pulmonary tuberculosis, we get evening rise of temperature. In pneumonia, it is usually high grade fever. Comorbidities like diabetes, HIV, underlying COPD over which acute exacerbation can be there. Personal history is very important to ask about the addiction like smoking, drug use, occupational exposure, because pneumoconiosis or many other occupations lead to respiratory diseases. This is important whenever there is an allergic or hypersensitivity reaction which runs in the family. Now this I have already explained. These are the common symptoms. What questions should be asked pertaining to these symptoms? Past history is important of diabetes, any cardiac event or hypertension. History of tuberculosis in the past very important because many times the residual fibrosis is there upon which superadded infection can be there. Past history of allergy or asthma in childhood, that's important. Any similar type of illness when patient present. So these are all points to be taken in history. In personal history, smoking, how much patient was smoking, whether is current smoker or in past. Alcoholism, chula exposure is very important, especially in villages in the females. Occupation exposure in industries, construction sites, or if there is exposure to pets, that lead to hypersensitivity pneumonitis. Type of house, that is socioeconomic status is very important because in many areas where persons are living in slum areas or closed houses, there can be cross infection from one to another. Physical examination, general physical examination to see any sign like cyanosis or clubbing, etc., or pedal edema. Respiratory system examination, as we have done in MBBS, that is still important in field practice and in academic institute, even during post-graduation. Inspection, palpation, percussion, auscultation. All these points will lead us to some diagnosis or some differential diagnosis, which we should keep in mind. In general physical examination, we have to see whether patient is conscious or not, patient's BMI, height, weight, temperature, pulse rate and rest. respiratory rate. Then in general examination comes pallor, icterus, the same as we have done in our MBBS exam teaching. Inspection lead us to many clues. When patient is examined, mostly patient should be examined in standing position. Shape of chest, as barrel shaped chest is suggestive of COPD or asthma. Whether there is a bilateral symmetrical, if there is any bulge or any retraction shows us that there is some fibrosis or decreased volume of the lung. Drooping of shoulder is important. Subcostal angles, chest movements, whether they are bilaterally symmetrical or some restriction. Tracheal deviation, usually trachea is in center or slightly towards right. But if there is a shift, prominent shift of trachea, that shows either there is decreased volume in the affected side or increased volume in the opposite side. Intercostal, subcostal retraction. Supraclavicular hollowing shows that there is a fibrosis in the apical portion, which is very common in tuberculosis. In palpation, we see any area of tenderness. We also see AP diameter or transfer diameter. In COPD, this diameter changes. Expansion of chest, whether it is equal on both sides. Is there any rib crowding, respiratory movements, tactile firmness, which shows if there is underlying consolidation. Percussion, very important in pleural effusion, we say stony dullness is there, or if there is a underlying consolidation on percussion, there is a impaired note. Auscultation is very important. Rhonchi, there are added sounds like rhonchi as it occurs in asthma. Crackles, dry crackles like on dry leaves crumbled. That is very common diagnostic sign in ILD. There are different type of breathings. Tubular as in pneumonias. Cavernous breathing as in the cavity. Amphoric whenever there is a bronchopleural fistula. Sometimes in initial stage of pleural effusion, we just hear pleural rub also. So based on this history and physical examination, it takes time to ask all these questions, and particularly objective asking about the details of the symptom or on examination. We should reach to some provisional diagnosis so that we can advise appropriate investigations. So we should keep in mind after physical examination and history taking what are a possible differential diagnosis. This will narrow down the investigations required and sometime we can start empirical treatment also before our investigation results come based on the severity of the disease. Now coming to the diagnostic tests, they are important for confirming that disease. The wide variety of investigation choices are available, but keep it in mind that in every case, we do not need all the investigations which are available. Based on our history and physical examination, we have shortlisted few conditions. Based on these conditions, we usually want 100% diagnostic confirmation, but in some cases, we have to follow our intuitions and clinical experiences also, what investigations are to be done and whether some empirical treatment is required or not. So diagnostic tests are available in different forms, like biochemical tests are available, microbiological, when we have to confirm some organism which may be responsible for disease. Serological tests are important because we can test some antibodies in case of allergic or some antigen particular to some infection. Pathology is very important whenever we take biopsy during bronchoscopy to confirm the diagnosis. Radiology, that's the most important investigation, and I think that is the first investigation to be advised in case of respiratory infection, exit chest. But now after exit chest, now we have got many different types of ultrasound, CT scan, different investigations are available under radiology head. So for this investigation, we need a number of samples. Most commonly the sputum sample, which is easily available, non-invasive, can detect etiological agent many times. Sometimes even malignant cell can be seen in the sputum in cases of malignancy. Bronchial lavage is sample. If sputum cannot help us, then we take bronchial lavage during doing bronchoscopy. That sample can be tested for biochemistry, for bacteriological agent, for even molecular tests, like ball is very important test when we do gene exploit for tuberculosis if it is not detected in the sputum. Biopsy sample, biopsy can be taken by IBUS under endobronchial under ultrasound guidance from any mediastinal lymph nodes. Biopsy can be taken during bronchoscopy also from the different parts or at the site from the site of lesion. We can do close lung biopsy also. First, patient is empyema, pleural fluid. If patient is having pleural effusion, pleural fluid is the investigation examined. Can be aspiration can be done easily. Can be examined for biochemical investigation, for microbiological investigations. Even gene expert can be done if we are suspecting tubercular pleural effusion. Blood examination whenever the respiratory disease has its systemic examination, like if there is a disseminated infection or if it is septicemia, can do blood culture also. In blood investigation, we can see liver function test impaired or CBC, complete blood count, showing the infection, which type of whether it is acute or chronic, or even CRP is done sometime to see the severity of disease and to see prognosis of the disease during treatment. Radiological number of investigations are, we start with X-ray chest, can be plain X-ray chest, we can take lateral view of X-ray chest to localize lymph nodes in mediastinum, can go for CT scan to see minor details, PET scan to see if there is a concentration of material at the site of inflammation, especially done to rule out malignancy. Then contrast enhanced CT scan can be done to see minute details. VQ abnormalities whenever there is a COPD or there is a vascular problem, that can be done. Ultrasound chest has become very important to differentiate between pleural thickening and pleural effusion and to confirm the extent of effusion, how much fluid we can aspirate from the chest. Interventional, these are the interventional investigation nowadays. Thoracoscopy is very important to see the pleural diseases. So not only we can see the lesion, we can take biopsy from the affected part like in mesothelioma or in tuberculosis. Flexible bronchoscopy, bronchoscopy is two types, like rigid, which is difficult to do and can do harm. Flexible is very easy, we can reach up to the terminal bronchioles, we can see the lesion, we can do aspiration, we can take biopsy also. IBUS, very important and very frequently done in mediastinal lymphadenopathy. Under ultrasound and guided, we can do aspiration from the biopsy. DLCO, we can do the pulmonary function test with that. Spirometry for pulmonary function test. And pulmonary function test can be done to see the severity of disease. Bronchoscopy is very important. Fiber optic and rigid. Fiber optic can be done without any anesthesia. We can reach up to the third order bronchi, commonly used not only for diagnostic but therapeutic purposes also. We can see if there is any bleeding vessel which can be coagulated. So this has become a standard white light flexible bronchoscopy. We say it's a type of bronchoscope, flexible is choice. Rigid, although the diameter is more, we can see, but we can only access to the proximal airways, difficult to introduce. It is an interventional investigation which is not preferred if flexible bronchoscopy is available and can be done. There is large state metal tube with the beveled distal end, can be inserted through trachea or through mouth. Thoracoscopy, two types, it can be diagnostic or video assisted thoracoscopy can be done. Indication, I told you, pleural effusion. If there is a malignancy is detected and we want to see the staging of the disease, how much pleura is involved, whether pleura has involved or not. In diffuse lung diseases, very important to take lung biopsy through this, and pleural lesion biopsy can be taken. VATS is usually done when there is loculated collection of fluid in the pleura. Sometimes some bullas are there which are at the verge of rupture. We can do bullectomy also. And then pleural disease. Sometimes there is recurrent pleural effusion accumulation. So through VATS, we can introduce some adhesive material so that parietal and visceral pleura that get stuck with each other, no potential space, no further fluid collection. So what are the common conditions we encounter? Pneumonia, that's an infective disorder. Community acquired pneumonia is most common disease which we encounter. After that, COPD, used in old age, smoker patients. Asthma is another condition which is sometimes episodic and sometimes become chronic also. In COPD, which is a chronic disease, but acute exacerbations are common. Mostly during this winter season, patients of COPD who is very well managed, they come with a superadded infection or acute exacerbation. Pulmonary tuberculosis. This is a common disease, infective disease. Most common is the pulmonary tuberculosis occurs in the lungs. Up to 80% of TB cases are in the lung. Very infective, very easily spread, but very simple to diagnose. There is only by sputum microscopy we can diagnose it, and with the molecular test, within 1 hour we can make the diagnosis of TB. CA lung, mostly in smokers, old age patients, this is encountered. Then pneumothorax. In COPD patient, many times there are formation of bulls which can rupture at any time and cause pneumothorax. Sometimes in trauma, whenever there is chest trauma, there are chances that there is a pneumothorax or hemopneumothorax which occur. Now, we will see diseases which are common one by one, how to diagnose, how to manage, but our main emphasis will be on the pneumonia, which we will do in detail. So, approach to managing asthma, symptoms are very common: cough, wheezing, chest tightness, allergic manifestation, seasonal variation. So, this is episodic. Sometimes it becomes chronic asthma, and sometimes it becomes status asthmaticus, when asthmatic attacks occur in sequence, no relief in between. Most common physical examination finding is bilateral wheeze, whenever patient gives a history of allergic manifestation. Very easy to diagnose on X-ray examination. We can see there is air trapment. Spirometry is important, which will show FeV1 is decreased, and reversibility. The reversibility is characteristic of asthma, and it can differentiate between COPD and asthma. Reversibility means we do pulmonary function test and see the response, and if after that doing baseline PFT or spirometry, we give bronchodilator by inhalation, and after half an hour we see the response. If patient has improved, there is reversibility that goes in favor of asthma. Then treatment, there are guidelines available, global guidelines are available, and mainstay of treatment nowadays is inhaler therapy. Advantages: dose is microgram, doesn't get much absorbed in the blood, so less chances of side effects with the drugs. Inhaler therapy most commonly uses long-acting beta agonist. Long-acting beta agonist with inhaled corticosteroid. That is the inhaler, or it may be given as nebulizers also. Combination available in market which frequently is used is formoterol and budesonide. Budesonide is a steroid, formoterol is a long-acting beta agonist. This is very common, can be given by inhaler or maybe by nebulization. Add-on treatment could be antihistamines can be given if we think that it is allergic to something. Patient may need short course of steroids if patient doesn't respond or patient is in severe condition. Steroids can be given based on the patient condition only, or even IV steroids can be given to tackle the emergency. So this is usually commonly encountered during changing seasons, like in November because of winter season, change of temperature, and then again in March, April because of the pollens, there is allergy to the pollen. COPD is another common condition. COPD affects lungs, but it has got systemic manifestations also. If it is not managed properly, it can lead to many complications, could be life-threatening. There are chances of acute exacerbation where symptoms are worse and patient needs to be managed. Can be diagnosed based on the X-ray. X-ray shows barrel-shaped chest. That's one thing which can be seen on examination also. Air trapping and bronchoscopy markings are very prominent. Sputum culture is usually done to see what is the infective organisms. Blood investigation like ABG, we see whether there is a hypoxia or there is a retention of carbon dioxide, or CBC complete blood count is to see what is the which type of infection it is. If CBC is raised, then there is increase in neutrophils, it's acute infection, or if it is increase in lymphocytes, it is chronic infection. Gold guidelines are available for the management. Latest guidelines are 2023. Every year guidelines are changed. Guidelines are freely available on the net. Even summary of guidelines are available, which are usually given by the medical representatives of doctors to see what are the current recommendation for treating the COPD condition. Again, like asthma, first line of treatment is inhaler therapy. Inhaler therapy may be by inhalation or maybe by nebulizer. Frequently used combination is LABA and LAMA, long-acting beta agonists like formoterol and tiotropium. Freely available in the market, this combination. Sometimes, if allergic component is seen, like if blood eosinophil is more than 150, then budesonide like inhaler corticosteroid is also added. Antibiotic is required only when there is a acute infective exacerbation. Dr. Sangeeta will tell you in her lecture that we should do judicial use of antibiotics only if it is required, and if it is to be given, it is to be given for a shorter period. 5 days antibiotic for a respiratory infection in pneumonia or acute exacerbation may be sufficient in routine. But many times what has been seen in the practice, long duration, 2 weeks, 3 weeks, 4 weeks antibiotics are given, which leads to the development of resistance to the antibiotic, which is, I think, the main target of this association. Madam is always stressing on avoiding development of resistance to commonly used antibiotics. So antibiotic may be used to tackle only when there is a infective exacerbation, or if you see any evidence of infection, like if sputum is yellow colored or green colored, or if there is a constant fever, then expectorants like terbutaline and bronchodilator may be used to remove secretion, because there is in COPD there is increased secretion of mucus, because this is one of the pathology involved in COPD, that there is an increase in mucus glands. Approach to pneumonia. This is our main focus in today's discussion. So in pneumonia, patient usually presents with fever, which is usually high grade, cough, dyspnea, and pain chest. Pain chest is because of the overlying pleural involvement. First investigation, as in all respiratory diseases, X-ray chest, we can see the finding of pneumonia as consolidation, or then CT scan can be done to assess the extent of pneumonia. Sputum microbiology very important to diagnose the infective organism. In many cases in pneumonia, some tuberculosis bacilli, or if we see the bacteria, based on the bacteria can be done culture sensitivity also, so that specific antibiotic can be given to treat that pneumonia. Blood investigation, CBC, CRP. CBC tells us whether it is acute or chronic type of infection, how much is the severity based on the increase in total blood count. CRP also shows severity of the infection. Treatment will depend on based on the causative organism. We have to identify the cause of pneumonia in every case. However, in severe condition, we may start some empirical treatment. If patient is highly febrile, breathlessness, severe pain chest, empirical antibiotic can be started, but we should try to ascertain the cause. We must rule out tuberculosis in any case. Antiviral, which are very common in children, small children. Antifungal infection are common whenever there is a decreased immunity, like uncontrolled diabetics or HIV infected person, patient living with HIV. Supportive therapy may be required as per the symptom, like antibiotic, may require some oxygenation, oxygen, or nebulization if there is a severe infection and secretion get impacted. So what is pneumonia? Pneumonia is inflammation of the lung parenchyma distal to terminal bronchial. So lower respiratory tract is involved. It causes alveolar gets filled up with the exudate and pus, leads to consolidation, which can be diagnosed on examination as well as X-ray examination. Severity can vary from mild to severe. Pneumonia can be life-threatening in immunocompromised patients, especially. Causes: Most common cause of infection are bacteria. Common bacteria are pneumococcus, H. influenza, staphylococci. Second common cause is viral. Viral are very common in children and immunocompromised patients. In rhinovirus, and latest example is COVID-19 that was causing respiratory pneumonia. That was the first and most common pathology which we got in COVID cases. Fungus, they are common only in immunocompromised patients. Mucor, which occurred in COVID-19 cases also. Aspergillosis, very common in post-tuberculosis sequelae patients. Then PCP pneumonia is very common in HIV. So these are a typical type of fungal infection which are encountered in respiratory diseases in specific groups. Some atypical pneumonia are also encountered like Legionella, Mycoplasma, Chlamydia. These are the bacteria, we say they are opportunistic bacteria. In immunocompetent persons, they do not cause pneumonia. If they cause pneumonia, they are not lobar pneumonia as caused by the bacteria. May lead to fibronodular shadows or some diffuse shadows in the lungs. Symptoms are pneumonia, fever, usually high grade, sometimes with Rikers also. Cough is there. Sputum production depending on can be non-productive in viral infection and productive with purulent expectoration in case of bacterial infection. Typical color is there in many bacterial infection, typical to certain bacteria. Chest pain is usually sharp and stabbing pain that worsens of deep breathing or coughing. This is because of the involvement of overlying pleura, and whenever patient coughs or speaks loudly, there is rubbing between the visceral and parietal pleura leading to pain. Breathing difficulty is there. Blood-stained sputum or hemoptysis can be there whenever there is a cavitary pneumonia or in fungal pneumonia, very common. Malaise and myalgia may be systemic symptoms because of the bacterial infection. Signs, tachypnea and tachycardia are common because of the severe infection. Abnormal breath sounds on percussion node, it will be dull on and percussion node when we say tubular breathing is there. Cyanosis can occur because there is a disturbance in gas exchange, involvement of lung which becomes solidified because of the secretion. There cannot occur gaseous exchange. Confusion in old age is common, that is because of the hypoxia and severe infection. Examination of chest, that is the first investigation to be done. Movement is diminished on the affected side, that is on examination. There are signs of respiratory distress because one portion of lung is involved which is not allowing gas exchange to be occurred, that leads to tachypnea and use of excessive muscles. Movements are reduced on the affected side if vocal fermentation is increased because directly from the bronchi sounds can be transmitted on palpation. On percussion, there is a dull or impaired note. It can become stony dull in cases of full consolidation or if there is a pneumonic effusion, slight amount of effusion over the consolidated lung. Auscultation, bronchial breathing, tubular type of bronchial breathing, they are very common. This is a common sign and common case given in the MBBS examination because it gives pneumonia, gives typical finding on examination as well as on the radiological examination. This is a picture showing that what happens in pneumonia whenever the bacteria reaches alveoli, there is uncontrolled multiplication leading to cytokine production which causes destruction of inflammatory cells and leading to formation of secretions in the alveoli, and when there is a merging of all the alveoli lead to patchy pneumonia and then consolidation when it spreads. After radiology, usually XHS is sufficient for a case of pneumonia. Sometimes may require CT scan to see the extent of disease or any associated disease underlying. Ultrasonography to see whether there is a fluid or not associated. Microbiological investigation, sputum, germ staining, culture to see whether infected organism. QH mountain to see fungal infection as in old age patients. And sputum for AB is must in any case of pneumonia because in case of pneumonia because tuberculosis is a very common cause of pneumonia. Biochemical investigation to see CRP and complete blood count. Swab test and serology. This is only important in viral etiology. Whenever we see It can be viral etiology, we should do this test. Bronchoscopy and bronchial lavage. When we do not get in initial stage of pneumonia, if we are not getting sufficient amount of sputum and if there is no expectoration, then we want to see the etiological agent. At that time, bronchoscopy is important. Fluid investigation are important when there is sufficient fluid in the pleura and we can aspirate it. Pneumonic is very minimal type of fluid that is reactionary usually, but whenever feasible, if fluid is there, we can examine it also. If what we see in radiology, there is a lobar consolidation. Lobar consolidation is a sign of bacterial pneumonia where single lobe is involved. And many times we can differentiate tubercular and bacterial pneumonia because bacterial pneumonia respects anatomical boundaries, that is horizontal fissure and oblique fissure. While tubercular bacteria, they do not respect anatomical boundaries. So only this sign we can think of whether it is a tubercular or non-tubercular. And sometimes bulging fissure sign, that's very important, like in Klebsiella pneumonia. There is a lot of secretion get collected in the alveoli and in the lungs, and there is a bulging of horizontal fissure. So simply see horizontal fissure, whether it is maintained or not. If it is bulging, it goes in favor of Klebsiella pneumonia or necrotizing pneumonia. Any necrotizing pneumonia could be there. If horizontal fissure remains same or gets retracted, usually there is a bacterial pneumonia. If horizontal fissure is not respected and infection traverses the boundaries, anatomical boundaries, they go more in favor of tuberculosis. Air bronchogram is a very important sign on radiological examination. As you can see, air bronchogram sign, if underlying bronchi are patent, so they can be seen as a black line shadow. They delineate the bronchi which are patent and there is a air in the bronchi, and in surrounding area, because of the consolidation, because of the collection of secretion, we cannot. Similar air bronchogram we can see in the CT scan also. Pleural effusion, sometimes pneumonia is related with pleural effusion when infection travels to the lung. In pneumonic, that is only inflammatory reactions, while in pleural effusion, if it occurs after the pneumonia and infection travels to the lungs, then many times also. So this is seen, there is obliteration of angle and rising shadow towards the lateral aspect, opaque shadow, which can be seen on the radiological examination. We can do aspirate. Increased interstitial marking, these are very common on viral diseases. They are fine, linear or reticular opacity, more common in pneumonia, can be sign of inflammation or thickening of the lungs interstitium. Whenever there is interstitial marking increase, there is thickening of interstitium which disturbs gaseous exchange from the lung. Cavitation, important of many diseases, lung diseases like in tuberculosis, there are multiple cavitation, especially in upper zones. Otherwise, if there is a bacterial infection, frequent and thin-walled cavitation, they show staphylococcal or Klebsiella pneumonia. In mucor or fungal infection, also we can see cavities. Ultrasound is important to see whether there is effusion or not. If effusion is there, how much is the amount of fluid, whether it can be aspirated or not. Sometimes when there is minimal effusion, ultrasound guided tapping is also done. So based on the involvement of lungs on X-ray, we can make some diagnosis. As I mentioned, that lobar consolidation is because of bacterial infection. If the boundaries are not respected, tuberculosis. Bilateral or upper lobe homogeneous consolidation can be staphylococcal or mycoplasma pneumonia. Upper lobe is commonly involved in aspiration. Lower lobe is commonly involved in aspiration pneumonia. Whenever there is aspiration, secretion usually gets settled in the lower lung. Bulging fissure sign, very important, of Klebsiella. Bronchopneumonia, staphylococcal. Interstitial infiltrate, usually viral or mycoplasma. So like this, there are certain signs which point out towards a particular etiology. Cavity lesions, whenever we see cavity in the pneumonia, cavity in the consolidation, if it is upper lobe, either it is mycobacterial tuberculosis or rarely non-tubercular mycobacterium. Unilateral or lower lobe involvement, it shows anaerobic bacterial lung disease, because whenever there is an aspiration of gastric tract, it goes to the lower tongue. Pleural based multiple shadows, they occur usually in opportunistic fungal infections. Cavities are common in Staph aureus and Pseudomonas. Pleural effusion, common in any bacterial infection, it can be then, like severe form of Staph aureus, Streptococcus pyogenes, or S. pneumonia. Pneumatocysts we see, these are very thin-walled air-containing spaces, commonly seen in Staph aureus. Rather, we say sometimes it is diagnostic of Staph aureus, mainly in children. Multiple nodules can be seen in the fungal infection. Microbiology is the mainstay of investigation, sputum examination. Typical color of the sputum on neck examination. Rusty is seen in streptococcal pneumonia, purulent and Staph aureus. Pseudomonas usually produce green colored, and Klebsiella red currant jelly. These are very important clinical pointers on neck examination. Like in Klebsiella, which is very anaerobic type of infection. Opportunistic infection usually occurs in immunocompromised condition. Most common resistant to the usually used antibiotics in pneumonia. Creates mucus which looks like red currant jelly. Pseudomonas, typical green color expectoration. Rusty sputum we see in pneumococcal, or it may be because of some blood stain. Other investigation could be CBC, where CRP and TLC is raised. Swab test is important to diagnose or rule out COVID or H1 infection. Serological test, usually when we see atypical agents like mycoplasma or scrub, we can see many antigens in the blood. Sputum KH mount is done usually to detect fungal infection. Now, risk factors for pneumonia, when we should suspect that these are the factors where pneumonia can occur. Extreme age of age in infants and old age pneumonia are common. Immunocompromised status, uncontrolled diabetes, chronic steroid intake, HIV/AIDS, they all decrease the immunity, where even less virulent organism or opportunistic infection can cause pneumonia. Post-transplant patients, because they are usually lying down and they are getting immunosuppressive drugs. Environmental pollution, occupational pollution is common. Poor socio-economic status, because they have got less immunity. Cross-infection, overcrowding. Smoking and chronic alcoholism usually decreases immunity. So these are the factors where we find pneumonia. For clinical purpose, we divide the pneumonia in 4 types. Community acquired, where person get from the community, from one another, and this is commonest form. This is the community center setting. Most common agent is staph pneumonia, and second common is influenza. Usually they present as lower pneumonia, response early to the antibiotics. Hospital acquired, they are a nosocomial infection. They are the pneumonias that occurs 48 hours or more after hospital admission. These are hospital acquired pneumonia. Most of the time they are resistant to routinely used antibiotics. Usually they are gram-negative organism like Pseudomonas, Klebsiella. Ventilator associated within 48 hours of putting a patient on ventilator, nosocomial infection are important. And when they are acquired through ventilator, we say ventilator associated pneumonia. Aspiration pneumonia, it is because of inhalation of either oropharyngeal or gastric content into the lower airway. Usually lower lobes are involved. Usually necrotizing pneumonia with gram-negative organisms. So these are the different type of commonest organism are staph, H. influenza. These are the commonest organisms. Now, there is for management purpose, we have got 2 types of severity to assess the severity of pneumonia. Because based on the severity of pneumonia, treatment guideline is made depending on the severity, when antibiotic have to be needed, whether patient is to be treated outside the hospital, OPD patient, or needs admission. First and more common is curve 65. This is curve 65. This is the index, and then PSI is a pneumonia severity index. We will see what is the index, and based on the index, treatment is decided. 65, it is a clinical prediction tool to assess the severity of disease, mainly in the community acquired pneumonia. With the help of healthcare worker, we can assess. There are 5 indicators. C stands for confusion. 1 point is given. Confusion means if patient is confused using adult old age cases. U stands for if there is a blood urea increase than more than 7 millimole per liter. If respiratory rate is more than 30. If breathlessness, if blood pressure, systolic blood pressure is less than 90. diastolic less than 60, again 1 point is given. If it is 65 age above 65, 1 point is again. So there are 5 points. Based on the 5-point curve score is given, and based on the curve score, treatment is guideline are there. So just to show you, if score is 0 to 1, either no point is there out of these 5, or it is 1. We say risk group is 1. 30 days mortality in it is only 1.5%. It is a low risk. Consider home treatment. Means we put the patient on treatment. Patient can be treated in an OPD basis. If curve score is 2, means there are 2 out of these 5 factors are present, risk group becomes 2, mortality, 30 days mortality increases to 9.2%. Probably admission or close outpatient management. So either patient should be admitted, or if it is on OPD, we should closely monitor the patient. 3 to 5 means either 3, 4 or 5 points are there out of these 5. Risk gap is 3. 30-day mortality reaches up to 22%. So 1/4 of patient we are going to lose. Such patient need admission. They are managed as well, maybe without ICU or with ICU. Mostly we require ICU. So this curve 65 score guide us how to manage. Similarly, is pneumonia severity index, where there are different points like demographic point of age, male, female, or nursing home residency. If there is a comorbidity of pneumonia, liver disease, cardiac heart failure, cerebrovascular disease, renal disease, if on physical examination or some laboratory parameters, based on this risk class is given. Similarly, as per the risk class, which is 1 to 5, recommendation is patient should be in 1 to 2, patient should be outpatient, in grade 3 outpatient with brief inpatient treatment, 4th and 5 is inpatient. In our standard treatment guidelines, which are released by this society, we are using in that pneumonia chapter that curve guideline, curve scoring, and most of the times clinicians follow this curve scoring for assessing the severity and how to manage the patient. So if we see in a flow chart, if there are signs and symptoms suggestive of pneumonia, or if there is X-ray suggestive pneumonia and criteria met for community acquired pneumonia. If there is no pneumonia, then we think of alternate diagnosis. So if a patient is having sign and symptom of respiratory tract, criteria is not met for CAP, community acquired pneumonia, or X-ray shadow doesn't show any pneumonic shadow, we should think of an alternate diagnosis. If there is a criteria met for community acquired pneumonia, means there are symptoms, X-ray shows lobar involvement or lung involvement. If it is yes, what we should apply curve 65 criteria. These are the 5 signs which I told you. Based on these signs, 1 to 5, we assess the severity 1, 2, or 3 severe grading. According to the grading, we start the treatment. Like if there is 0 to 1, means either there is no point out of the 5 scores, or if there is a 1, such patients need home antibiotic. No admission is required. Maybe admission required because of social reason or some comorbidity. Otherwise, such patient can be managed outpatient. If the score is up to 2, means 2 signs are there out of the 5, hospital is required. We need supportive care. We need investigations also, and antibiotics are to be given. If it is 3 to 5, means 3, 4, or 5 scores are there, then such patient needs hospitalization with ICU facility. So these patients should be admitted initially in ICU, investigation to be done, and antibiotics to be given as per the culture sensitivity report. So curve 65 score help us in assessing the severity of the disease and guiding us for the treatment. So for treatment of acquired pneumonia, it should be done as OPD based patient treatment. A patient should be stratified if there is a comorbidity or not. In severe cases, even beta-lactam antibiotics are also recommended. For outpatient with comorbidity, oral therapy is recommended. In pneumonia, one point is very important. Fluoroquinolone should not be used as empirical treatment. May be used in cases of severe pneumonia, 3 to 5 score, when patient is in ICU, fluoroquinolone may be used. Otherwise, it should always be avoided in any respiratory tract disease, any pneumonia, because fluoroquinolone are one of the important drugs to be used for drug-resistant tuberculosis. We never know that pneumonia can turn out to be a tuberculosis on later stage. So we should prevent it. We should not give it until unless it is definitely required in ICU patient or there is a evidence of the culture sensitivity. Antibiotics should be given in appropriate doses to prevent emergence of drug resistance. Geeta in her lecture will highlight this point. We should make judicious use of antibiotics for period till when it is required, not more than that. And we should choose antibiotics based on the culture sensitivity. If patient is admitted in the ward, so antibiotic of choice are beta-lactamase plus macrolide. So we give combination of drugs, and preferred beta-lactamase are cefotaxime, ceftriaxone, and moxiclavir. So we usually give in combination. If there is hypersensitive beta-lactam, then fluoroquinolone can be used. Patients should also undergo sputum examination for OAP. This is very important in every respiratory disease. Route of administration can be oral or parenteral depending on the judgment of treating physician. Follow-up and supportive treatment is very important. Antimicrobial treatment should be changed according to specific pathogen. In many cases, if patient condition is severe, we start empirical antibiotic, but immediately after getting a culture report, specific antibody should be given. Supportive treatment is required if patient is not responding within 48 to 72 hours, then and there are development of complication or drug resistance, then further action has to be taken. For patient in whom viral pneumonia is suspected, oseltamivir 75 mg BD for 7 days. Best outcome if treatment started within 48 hours. So in every case of pneumonia, viral or bacterial, treatment should be started within 48 hours to get better outcome. Steroids are not required for non-severe condition. Only in severe condition, when patient is in ICU, not responding, there are blood investigation which shows unfavorable response. Only then steroids are to be given. Only septic shock or patient is ARDS. Steroids have got crucial role in viral pneumonia because it reduces inflammation and prevents fibrosis also. In diabetic patient, control of blood sugar is very important because if blood sugar is not controlled, it is very difficult to control the infection. Other investigations, other therapeutic like antibiotic, IV fluids, sometimes patient is in acute respiratory failure, that patient should be put on ventilator. Duration of treatment is important. In outpatient, oral antibiotic for 5 days is sufficient. 5 days oral antibiotic. Inpatient could be given initially intravenous antibiotics and then oral antibiotics for 5 days can be given. IV is given till patient improves. Longer duration of treatment are needed only in inpatient when there is a atypical pneumonia like Legionella pneumonia or there is a bacteremia leading to septic shock. With meningitis or endocarditis or complications of pneumonia, lung abscess formation, empyema, maybe longer treatment is required. Prevention is very important, like in this season, vaccination for viral infection like pneumonia and pneumococcal influenza. These two vaccinations are very important, especially in old age patient or patient of immunosuppression. Smoking cessation, good hygiene, control of blood sugar and diabetes is important for development. Now, after pneumonia, we come to ILD. Brief points about interstitial lung disease. Patients can be usually patient complaints of dyspnea, which is progressively increasing. Patient can cough, usually dry cough. Patient can present as acute, subacute, or chronic presentation. CT is the on excess chest we can suspect ILD, but confirmation occurs on CT scan. Blood investigations are used. There are different type of lung diseases to evaluate. Treatment varies based on the type of ILD. Most common drug used are steroids, which are the mainstay of ILD. Immunosuppressants are used, and then antifibrotic agents are used so that to further decrease the progress of the disease and fibrosis. Supportive treatment in form of oxygen and rehabilitation is very important. Approach to tuberculosis, this is a separate chapter indeed, but keep in mind that any respiratory infection we say any duration of cough more than 2 weeks, TB should be ruled out. Very simple to rule out sputum ARB, and now gene expert, which is molecular test, is available. In high risk groups like in HIV, uncontrolled diabetes, hemoptysis, we need not to wait for 2 weeks cough. Even the duration is less, even then TB should be ruled out. X is important to diagnose sputum ARB and CBNet. Anti-TB treatment for drug sensitive and drug resistant. CBNet usually tells about the rifampicin resistance also. Accordingly, we can start the treatment as per our guideline. CA lung symptoms are usually cough, hemoptysis, pain chest, loss of appetite, loss of weight. These are the common symptoms. Mainly the smokers and old age, we should suspect it. In old age, every respiratory infection, every pneumonia, we should rule out malignancy. CT scan helps in diagnosis, and final diagnosis comes on the basis of biopsy and histopathological examination. Biopsy can be done through bronchoscopy or closed lung biopsy. Now, newer modalities have also come, like immunohistochemistry can be done, or some molecular tests or markers are available now. Treatment will depend on the stage of the disease and presentation. There could be surgery, chemotherapy, radiation, immunotherapy can be used singly or in combination based on stage of the disease. Pneumothorax occurs whenever there is an acute onset of dyspnea with chest pain. We should suspect pneumothorax. XHS clinches the diagnosis. Treatment, if there is a minimum pneumothorax, can be absorbed easily. Patient just need rest. If there is a tension pneumothorax, urgent decompression is needed by putting intercostal tube. Approach to hemoptysis. Hemoptysis could be mild, moderate, or severe within 24 hours. If it is 100 ml, it is mild, moderate 100 to 600, more than 624 hours severe. Symptomatic treatment can be given by the antitussive or tranexamic acid, etc. Prevention, we should see what are the underlying causes. Most common causes are infections, sometimes in heart failure, pulmonary diseases, some vascular diseases, trauma, but malignancy must be ruled out if there is a hemoptysis of hemoptysis. Treatment depends on supportive treatment like rest, oxygen. We have to maintain their bronchial airway. If there is a hemoptysis, it should be aspirated immediately. Patient should avoid movement. Chest physiotherapy should be avoided, and basic cause is to be treated. To conclude, the approach to management of respiratory disease involves comprehensive evaluation. Evaluation is mainly on the history, examination, accurate diagnosis. Different diagnostic modalities are there, but all need not to be done. Based on the clinical examination and history, we should shortlist the diagnostic modalities. Treatment plan should be tailored as per the disease confirmed, which varies according to the type of disease. Follow the basic chronological order while evaluating the patient. This helps very much. Which symptom develop first, then second, after how many days we can reach up to the some differential diagnosis. Multifaceted approach is required, which include history, physical, diagnostic examination, but mind it, in every respiratory tract, please rule out tuberculosis, which is very common in our country. Thank you very much for patient hearing. If you want to share your experience, if any clarification is required, you are most welcome.
Thank you, sir.
Thank you, sir, for such an elaborate and comprehensive presentation. In fact, I have got a query come clarification to request for.
Yes,
what would be the schedule of this polysaccharide pneumococcal vaccine in elderlies for first timer and for the repeat one?
Okay. First timer, one shot should be given in any patient, old age patient, at the start or beginning of the winter season. Every year, new vaccines come with the prevalent strains. So vaccination every year should be done in elderly patients.
Okay, this will be for the influenza and for
Yes.
the pneumococcal, sir?
Pneumococcal separate vaccine is available. Now it is recommended that both the shots should be given before start of winter season.
Right, sir. Thank you.
Every year. This is every year.
Yes, ma'am. This is every year, ma'am.
Yeah. There is one question about age of booster. PCV booster in children if not given earlier.
Okay. I'm not sure about it. Ma'am, if you can answer.
I'm looking at the CDC guidelines. I would have to look at the Indian immunization guideline. They say pneumococcal at 2 months, 4 months, 6 months, and 12 through 15 months.
Okay, okay. 2 months, 4 months,
6 months,
and
and
12 to
then
15 months.
12 through 15 months.
Right. There has been recent change in this immunization schedule.
I will have to look at
Okay.
the India
India
guidelines, but
guidelines.
this was,
Right.
yeah.
Ji.
I think, uh, sir, you will be around, or
Yes,
we
yes,
can
yes.
take the,
No,
okay.
I'll be throughout the session. I'll be online.
Okay. Then we can take the questions later.
Yes, yes, ma'am. You can finish your lecture first.
Can you, sir, stop sharing? I can then
Okay,
share
okay.
my.
Ji, ma'am, please.
Thank you, sir. Now we welcome Dr. Sangeeta Sharma, ma'am, a pharmacologist, and she pharmacologist. She is the president of DSPRUD, that is Delhi Society for Promotional of Rational Use of Drugs, NGO in the forefront of promoting rational use of medicines and improving accessibility availability of drugs. Since 1996, she has conducted more than 200 capacity buildings for doctors, nurses, and pharmacists. She has a rich and diversified professional and managerial experience in health, and one of the pioneering work in book, namely Standard Treatment Guidelines, a manual for medical therapeutics. Thank you, ma'am, and over to you, ma'am.
Can you see my screen?
Yes, ma'am.
Okay. Okay. I think Dr. K.K. Chopra has already elaborated on the presentations, the investigations to be done, and how do you arrive at a diagnosis. Now, I have, chosen to do it later because, when we go to the clinics and when we look at the prescriptions and when we interact with the doctors, we realize that there are certain some variations happen in a subtle way, because we have our own, certain myths, certain facts are not clear, or over a period, therapeutic advances have taken place. And if we are not able to switch to those, so it brings in, difficulty in treating these patients. So there is a need for standardization. We all know respiratory tract infections, they are a significant health challenge, and it has a lot of impact. We have guidelines being produced by different organizations, by international experts, by NHSRC, although this was the common infections in children, but these were developed in 2017. Then we have ICMR guidelines, pathways. I think 2022 pathways are also there, but I couldn't locate today. That page was not available. So they have also produced these guidelines, and ours, DSPRUD, we have been producing, revising these guidelines for last 20 years now. Seventh edition is under preparation. But despite having all these guidelines, we see that there are variations, and we are concerned about respiratory tract infections. One is because of the sheer magnitude of the problem, and second, why is it that people are getting more infections? Because there is inadequate emphasis on sanitation and hygiene practices. So infection prevention and control becomes very important. We have all seen COVID pandemic, which was very loud, and how it's quickly spread to almost entire globe within no time, within few months time. It had spread to all over the world, and the kind of morbidity, mortality, the impact on our productivity, economic cost we can all, I think we are living in a time then we should be able to appreciate the role of infection prevention and control. And third major important problem with respiratory tract infection is the development of antimicrobial resistance, because antibiotics are very, very commonly used in these conditions. And respiratory tract infection form a very important infectious syndrome, component because of the numbers that we treat. And so we know that there are certain myths about treating respiratory tract infection, although Dr. Chopra has already emphasized that most of the upper respiratory tract infections are viral in nature. Only few are bacterial. You can differentiate between them clinically, but somehow there is a myth that we take all infections as bacterial infections and we prescribe antibiotics. As you know, antibiotics are they will work only against the bacteria. They will not work against the viruses. But if having known this knowledge that 90% of upper respiratory tract infection is viral in nature, but if we look at our prescription, we find exactly the opposite, that the 90% of our prescriptions will have some antibiotic on some pretext or the other. Either we are not able to distinguish between the viral or bacterial, or many think that yes, it is a viral at present, but by giving an antibiotic, I'm preventing super added infection or secondary infection. And we saw this kind of problem in COVID pandemic also. Although diagnosis of COVID was confirmed, patient was mild to moderate only severity, but yet they kept on receiving the antibiotics just in case that this is bacterial, or I'm trying to provide prophylaxis for secondary infection. So then second major problem, even when indicated, when these antibiotics are indicated, many of us have different notions about the completion of courses. There are recommended duration for treatment of each of these syndromes, like Dr. Chopra already emphasized it very much. For non-severe community-acquired pneumonia, when you are treating them on the outpatient basis, only 5 days of treatment with antibiotics is enough. But in practice, that we see that these patients go on receiving these antibiotics for more than 10 days, 14 days. So that excessive duration of therapy also adds to the pressure of development of AMR. I hope you all know the magnitude of this problem. The magnitude of AMR is much, much more than the impact caused by COVID-19. Although we appreciated this COVID-19 very much because it was very loud, it was sudden, it struck us like tsunami, but we are not able to appreciate the impact of overuse, misuse, abuse of antibiotics and causing AMR, because it is a slow pandemic or a silent one, and the number of deaths would be much, much more, 10 million deaths every year by 2050. And this, do we want that kind of a situation? We have had a golden era of antibiotic, where a lot of antibiotics have been developed, and all our achievements today are because of antibiotics. Now think of a situation when you have all these antibiotics, but they are no longer acting. The patients are no longer responding. Simple infections which are amenable to treatment with simple antibiotic, first line antibiotics, you can imagine what can happen when they don't respond. One thing that we have learned over the past few decades is that germs have been smarter than us. They have always remained one step ahead of us. So no matter if you have a new antibiotic, they will develop some mechanism to defend themselves. So, and the position is worsened now because we don't have new antibiotics coming into the market. For last at least 2 decades, we haven't had any new class. What you have is the new generations only. No new class is coming. So we need to be, this is a great challenge that we need to be looking at it. Now, why do clinicians use antibiotics or overuse or misuse antibiotics? Largely, I feel the challenge is because we are not able to differentiate between viral and a bacterial infection. So one reason could be that we have limited or accurate diagnostic tools to differentiate between. Have we had the point of care rapid testing available like we had for COVID? It did reduce some certain number of prescriptions for antibiotics, but overall that impact was not seen on antimicrobial prescription. So to me, even if you are able to diagnose, I feel, I think Dr. Chopra will endorse that. The diagnosis of upper respiratory, lower respiratory pneumonia is clinical. Most of the time you can do it clinically, plus radiology will help you, but yet we see, if we are able to do that, make the diagnosis, still, we know that this is viral, antibiotics are prescribed. So this becomes more of a behavioral issue, because it could be because of the time pressures that we have, heavy patient load we have, or it could be fear of complications. Some people tell me that they prescribe antibiotics to save themselves, safeguard themselves from litigation, especially those friends who are in private sector. They are worried about the litigation. So most of the time it becomes a defensive practice. And, many times we are influenced by the peers, colleagues. If I don't prescribe, somebody else will prescribe. So why not let me do it? Or, after some time, if I'm able to, I have to add antibiotic, why not from today? There is a concept called watchful waiting that has been introduced to reduce the use of antibiotics in outpatient department. When you see these patients in outpatient OPD, delayed prescription, many people refer to as a delayed antibiotic prescribing, because even the sinusitis most of the time is viral in nature. You don't need. So these upper respiratory tract infections, sinusitis, they are self-limiting illnesses over time. So all you need is watchful waiting. If you know the red flag signs, when it has become bacterial in nature, so we can reduce certain number of antibiotics. So then, many of us, I think, somehow have over believed in the power of antibiotics. As I said, antibiotics will work only against the bacteria, not viruses. And patients also think, we mix up severity with the seriousness, and the more high the fever, we think that this is more of a bacterial in origin. So you need a stronger antibiotic, and these are better, and there is nothing called, secondary prophylaxis here. If you recall your pharmacology, there are only few indications where prophylaxis with antibiotics like SABE, some certain dental infections, where rheumatic, SABE is the main this thing. Otherwise, there is no such indication. So what you need is to treat the patients. So, as you know, the upper respiratory tract infection, it can present as rhinitis, sinusitis, ear infection, acute pharyngitis. Now, again, if you look at these, these are the causative, the etiology of this is mostly viral. Whereas many of us think that sinusitis is there, then we need to prescribe antibiotics. Again, here, since this is mostly viral, watchful waiting will help. Delayed antibiotic. If you feel that the patient is not getting better over 5 to 7 days, the condition is worsening, or there is double sickening. Double sickening, the term is used. Patient was sick earlier, then patient fever reduced, started getting better, but then again the fever comes back again, or the clinical condition deteriorates. So that is called double sickening. Only when there is double sickening, or then you think that this could be bacterial, only then antibiotics are needed. Again, even acute pharyngitis, most of the time, half of them are viral or other. Only thing, antibiotics are needed for group A streptococcal. So many of us feel, since those of us who are working in remote areas, we feel that since we don't have enough diagnostic facilities here, so we try to compensate by giving antibiotics. That's not true. You don't need an investigation. Dr. Chopra also emphasized on this. Diagnosis is clinical. Routine testing is not required. All we need to be is careful about is the clinical features. History examination is very important, and most of the time these are self-limiting, so only symptomatic management is required. Now, there are certain clues that we can use, although these are not foolproof, but these are the clues that you can use, whether it can be bacterial or a viral. So generally in viral illnesses, two mucous membranes are involved. There will be watering, there will be running nose, so coryza, rhinorrhea, cough. A lot of cough will be there with viral. Fever could be there with both. Conjunctivitis would be there. So, a careful history can help you in deciding, whether other members in the family are also sick. If you have history that others also had a fever in 2 days before, 3 days before, the so and so also had a fever, so most likely it is viral. Bacterial don't spread it so quickly to others. So I think we are living in an era where we are not laying enough emphasis on history taking and clinical examination. We think unless we do diagnostic tests, we will not be able to manage this. So these are some of the clues. If there are exudates, tender lymph nodes are there or not. Young people would have streptococcal infections more. Occurrence would be more in cold weather, or history of exposure to streptococcal. All these would be there. If you can make out clinically whether this is bacterial or viral in nature. I think Dr. Chopra has already emphasized on, I think he mentioned about Centaur score, and he mentioned also about curve 65 score. In case, one is that you take clues from the history and examination. Second is that these scores, criteria have been devised to help us in differentiating. Many times, if it is clear-cut viral or clear-cut bacterial, no problem. But sometimes there are gray areas when we are not very sure what to do. So perhaps these are the situations where we can use, these criteria. Centaur criteria score is one of those which can help us in outdoor department in differentiating bacterial from viral illness. So as he already emphasized, this is a 4-point score, where temperature, if it is more than 38, lymph nodes are swollen, tender, there is tonsillar swelling or exudate, and absence of cough. You give it 1, viral will have cough, bacterial don't have much of cough. If it is age is 3 to 14 years, you give 1 score here, 15 to 44, 0, and if age is more than 45 years, minus score is given. So now based on this score, the lowest could be 0, 1, 2, or 3, or more than 4. Risk of streptococcal infection can be envisaged here. So if it is 0 or 1, no testing or antibiotic is required. If out of the 5 criteria that you have, if it is 0 or 1, no testing or antibiotics are required. More than 4, yes, you can go and treat empirically, even with or without culture. So even cultures are not needed, you can empirically treat. Now, in between are the 2 and 3 category. If group A streptococcal test is positive, then treat. If negative, clinical suspicion is high, then go for cultures here. So this is helpful. This center score is helpful to rule out tests to decrease antibiotic usage. Then point of care, we must utilize point of care testing for upper respiratory, COVID-19, influenza, group A streptococcal sore throats. These rapid card tests are available, so that can help us in differentiating the bacterial from. Now, lower respiratory, I think he has already emphasized on this. Clinical presentation, the patient may come with high fever, chills, chest pain, breathing, cough with or without expectoration, pleuritic chest pain. If it is less than, I think it is 2 weeks now, duration, then you can think of community acquired. If it is hospital healthcare associated, then, or if it is more than 2 weeks, then it is tuberculosis. Now, for pneumonia, he has already mentioned curve 65 score is, you can use it to decide whether these patients need hospital admission or not. So this will help you in deciding whether this patient is good for outpatient treatment or inpatient treatment. Whereas this ATS IDS criteria, this looks at the severity of the pneumonia. This will help you deciding whether this patient would need ICU care or not. So let's see, I think curve 65 score, at the cost of repetition, I would like to repeat it again. This is very easy. You can remember. C stands for confusion, U for uremia, respiratory rate more than 30, BP less than 90, 60, age more than 65. If all one score is 1 for each, this patient needs hospitalization, perhaps maybe ICU, but certainly you need IPD care for this. So score 0 or 1 is there. You can treat them as ambulatory outdoor patient. So, curve 64 will help you decide whether this patient needs hospitalization, whereas this criteria for severity, when the patient has septic shock, respiratory failure, of course patient needs ICU. Then there are minor criteria which can be used to decide whether this patient would need ICU care or not. Then pneumonia severity index is there. This is more elaborate one. Because it takes into consideration the comorbidities, the labs, and based on that, you can decide whether the patient can be. Some people prefer PSI, some people prefer curve, some even if you don't have the urea level. Again, this is a clinical scale. You can use it clinically. The NICE guideline latest one, they use CRB 65 score. That means all clinical. So based on that, they decide the treatment. So don't just think that, unless you have these investigations, you will be able. So generally, by and large, non-severe community acquired pneumonia. You don't need, you just need routine blood tests, CBC, TLC, DLC, CRP, chest radiograph, And even at the start of treatment you need it, but then there is a lot of variation in the requirement for end of treatment x-ray. I'll talk about this, whether a sputum culture should be done or not, blood culture should be done or not. Again, the easiest yardstick is, if it is severe pneumonia, go for it. Non-severe, these have no role. Or when you are specifically suspecting MRSA or prior respiratory tract infection, immunocompromised patient, unless you have those specific situations, there is no lab testing required for this. So I think this is the latest guidelines about this. The crux of it is non-severe. You don't need much investigations. If you are suspecting Legionella, pneumococcus, urinary antigens, then go for it. Influenza accordingly. If you procalcitonin, earlier it was used as an inflammatory marker, and the cutoff value was used to distinguish between viral and a bacterial illness. But now they say you can, if the procalcitonin levels are declining or declined, then you can take a decision to stop or de-escalate accordingly. So PCT is another modality that can be utilized for reducing the unnecessary antibiotics. Then I think Dr. Chopra has already emphasized on specific diagnostics when you are suspecting this clinically. Then, as I said, Curve 65 will help you in deciding plan whether outdoor, indoor, or ICU. I think our guidelines also specify that plan A is outdoor, plan B is indoor, and plan C is in the ICU. Now, accordingly, drugs have been if there are no comorbidities here, no risk factors for MRSA or Pseudomonas aeruginosa, then these patients can respond to amoxicillin, doxycycline, and macrolide. Although the latest one says the macrolide should not be used as a first line, amoxicillin and doxycycline are as good, but considering the resistance pattern, perhaps we can give azithromycin or clarithromycin as first line treatment. Then if there are comorbidities, then maybe we can go for amoxiclavulanic acid here or cephalosporins here. Or only as Dr. Chopra has already emphasized, fluoroquinolones should not be used as empirical antibiotics, as first-line antibiotics for outdoor department, only in certain situations that you need these for treatment of pneumonia. Now, coming to the duration, usually the dictum now is shorter the duration, the better it is. So there is enough evidence now. 5 days of treatment with first-line antibiotics for outdoor treatment is good enough. All you need to do is that you have to reassess at the 5th day at the end of the treatment that the patient symptoms have resolved. But otherwise, if you are suspecting streptococcal, 7 to 10 days, atypical, maybe a longer duration treatment with there, and of course severe pneumonia and acquired pneumonia, depending on the situation, 10 to 21 days has been advocated. Now, as I said, I think I will repeat here, this is important. Fluoroquinolones should not be used as first-line empirical antibiotics in pneumonia undiagnosed cases because of the AMR, because these are the reserved drugs for serious infections, especially these are used in TB, for MDR TB. And if we are using this rampantly, resistance is going to develop. And of course, fluoroquinolones have more side effects, and superinfection, Clostridial difficile infection risk is higher with fluoroquinolones. So they should be used only in certain settings, where you think that the first line is not going to work here. Okay, then assessment of response, I would like to repeat here again. This is again clinical. I have seen many people asking for X-ray every third day, fourth day, seventh day, 10 days. They look at, until the infiltration has resolved. Generally, there is a lag period between clinical improvement and radiological clearance. So don't just keep looking for radiological clearance. Clinical improvement, assessment of response clinically is good. If there is a fever is going down, respiratory symptoms are improving, heart rate has come down, respiratory has come down, BP has improved, oxygen saturation is maintained, and if you can repeat these laboratory parameters, CRP, ESR, and if TLC is normalizing, these are all indicators of response to these treatment. So improvement in chest X-ray or other imaging is not used routinely. Okay, only follow-up X-ray would be required if there is persistent or worsening symptoms. Or complicated, you think that there are some complication, effusion has happened, or abscess formation is there, or patient is immunocompromised, or clinical uncertainty is there about the diagnosis. So no end of treatment unless these problems are there, because like there is a irrational use of antibiotics or medicines, there is a overuse of these X-rays, radiological modalities as well. This lead to unnecessary exposures and the cost to the patient. Then I think Dr. Chopra is here. I will ask him to elaborate on this. One of the very common situation is the exacerbation of asthma and COPD, which are mistaken for infection in these patients, although the infections are quite common in these patients, but every exacerbation of asthma or COPD is not necessarily an infection. So it does not mean that every time the patient is going to get antibiotics. I've seen one patient in Maulana Azad. This was a 12-year-old child. He was sick, was diagnosed as asthma at the age of 8, and he had come to LN Hospital for dialysis. When we went into the history, we observed that since he had exacerbations, and each exacerbation was treated with aminoglycoside, gentamicin. And almost every month, he got a course of aminoglycoside by somebody in Punjab. And by the age of 12 years, he landed up with kidney failure. So, you may say, where does this happen? I'm quoting a real life example here. So, not every exacerbation, it could be part of the progression. So we need to be really very careful, when do these need patient? Of course, when a patient has bacterial infection, this needs to be properly treated, but not unnecessary treatment. And as I said, these guidelines have been there. You can choose, follow any of these, but adhere to these guidelines. And of course, vaccinations have a role. Vaccination, particularly those who are vulnerable, very young, elderly, people with diabetes, underlying heart disease, they are susceptible to severe infections. So they must use this. Earlier cost was a consideration, but I think considering the benefits of vaccination, this cost can, would be reduced. And vaccination in general will prevent key infections. It will develop herd immunity, and it will reduce the disease severity and prevent outbreaks. I think I'll stop here. If there are any questions, Dr. Chopra, I think one part, if you can elaborate on, acute exacerbations, which one needs antibiotic and which one, how do they differentiate clinically? And the next session is on pain management in terminal care, 20th January.
Yes, exacerbations are common in COPD and pneumonia. Before starting antibiotic, we should see if there is a infection evidence, if there is any evidence of bacterial infection. Bacterial infection, we can see if there is a patient is febrile. That is the first symptom. If patient becomes febrile, that shows there is some superated infection. Second, then on investigation, CBC, CRP. These are the two things which are increased. And even if there is some radiological abnormality and response to the routine and treatment for COPD and asthma which is being given, if patient responds to the routine treatment, aggressive treatment, no need of antibiotics. So antibiotics is required if the patient is febrile, if there is a purulent expectoration, if there is a leukocytosis showing neutrocytosis, if the neutrophils are increased, sputum is purulent, fever, not responding to the routine treatment which is to be given aggressively. Only in these evidences we should start treatment, otherwise antibiotics should be avoided to prevent development of AMR.
I think even now I had read, even earlier we were going by the color of the sputum. We thought that yellow means bacterial infection, but now there are studies it just says that there is some inflammation, does not necessarily mean that it is a bacterial. So you have to look at other features as well. Just turning it color changing to yellow or amount of sputum increasing does not mean that it is a bacterial infection. Okay, and now I think we can take some questions. There is a question about in atypical pneumonia, how to decide about viral or mycoplasma or chlamydia to start treatment.
You can answer it.
Hello?
Ma'am, you can answer this question, please.
I think it would be better if you take up this.
In any pneumonia, treatment is to be started whenever there are acute symptoms. Acute symptom means patient is febrile, there are radiological abnormalities. So treatment need to start in viral pneumonia or mycoplasma or chlamydia, depending on the sensitivity of the infection.
Then there was a question about duration of antibiotic therapy in ICU patients. I think hospital-acquired pneumonia, ventilator-associated pneumonia. How many days we should give higher antibiotic, and by which criteria we would stop antibiotics?
In hospital-acquired pneumonia or ventilator-associated pneumonia, usually the infection is treatment is required for longer duration. Initially, it is given IV medicine for 5 to 7 days. Total duration of treatment may be 10 to 21 days, but everything will depend on the patient's response and the evidence. Like frequent, we have to do CBC counts. Depending on the CBC counts, we can see whether infection has subsided or not. Clinical response of the patient. Based on that, duration can be decided.
Yes, I would like to add here, usually these patients on higher end antibiotics, parenteral ones, but we need to look at, can we de-escalate? Can we generally broad spectrum are initiated when the patient is very sick. If you have done cultures, blood culture and sputum cultures, by 48 to 72 hours, you will have a specific organism identified, pathogen identified here. So based on that, you can de-escalate. De-escalation could mean, if you have started with broad spectrum, you can switch to narrower spectrum, or when you started with antimicrobial therapy, you can switch to monotherapy here. De-escalation could also mean, if you have seen a sufficient response and the patient is stable for 48 to 72 hours, there's no fever, etc., then can you switch from IV to oral. So these are certain strategies, interventions that are available, because in the emergency situation, when the patient was sick, saving the life of the patient is very, very paramount here. But once you have identified the pathogen, you can make it more targeted treatment, and thus you can optimize the use of antibiotics for these patients. Now, one thing I think I forgot to mention was, when this patient is serious, you need to draw these samples, blood cultures and sputum cultures. These samples should be drawn before giving the first dose of antibiotics. Many times, in emergency, we have situations when we are in action, and we start with these antibiotics and we collect samples later. Even a single dose of antibiotics can render these blood cultures, sputum cultures sterile.
Right.
So if you want to best utilize these diagnostics, I think the one thing, take home message that we need to take is that we must take samples before giving first dose of antibiotics. I think. How often do we repeat sputum culture in VAP?
It can be repeated when we are trying to shift from parenteral to oral antibiotics, or if patient is responding. If patient is not responding, it can be repeated in 3 to 5 days.
I think this is also clinically driven, decision. If
Yes,
you think,
clinical driven.
if the patient is worsening, then perhaps you have to go for it. Then role of vaccination, I think, is same as for anyone. For asthma, COPD, this reduces these number of infections, because COPD, asthma patients are more prone to get these
Exactly.
infections. Then I think in the beginning there was one question about steroids in asthma. For how many days a steroid inhaler is preferable in asthma?
Steroid inhaler is the first choice. That is as per the global guidelines. Inhalers can be given depending on the response of the patient, because whenever we are giving inhaled steroids, there is no much absorption of the drug. So it can be, it all will depend on the clinical response of the patient.
Yes, I think they are the ones, patients need to be on. They will reduce the severity.
Yes.
They will reduce the exacerbations in between. So they are the mainstay of treatment. And actually, in practice, we see the reverse. We rely more on the symptom rescuer therapy rather than inhalational corticosteroids. And depending on the severity, persistence of symptoms, these can be continued, and they don't have much side effect, because you are delivering it directly local at the site of action. So they are, except for long term, mouth it can cause some oral thrush. But if you instruct the patient to wash, take the mouthwash, that should take care of the problem. Otherwise, it is very safe.
And even dose is in micrograms. Dose is also micrograms in inhalers.
Yeah. So we need not worry about the side effect. Patient can continue. I think. Are there any other questions? Drug of choice in walking pneumonia. I think you mean outdoor. I think I mentioned about amoxicillin, doxycycline, azithromycin, clarithromycin. These are the choices that you have. You can treat simple pneumonia with this in outdoor. In case of ILD, inhaled steroids can be given. If not, why not? Sir, ये आप लीजिए.
Inhaled steroids, they are given. They are mainstay of the treatment for ILD patients. Initially, we give oral steroids also to get quick response, and after that can be inhaled steroids, as well as we give that antifibrotic drugs also.
Are there any other questions? I think take-home messages are very clear. If you're not sure, explain to the patient red flag signs. I think pneumonia, you will not miss it. And most of the time it is upper respiratory tract infection. We think that it may not spread to become a lower respiratory tract infection most of the time, but upper respiratory ones are viral in nature. Watchful waiting is something that you can do. There is no harm in it. You can wait, explain. Always I say, if you just examine, take history, you will see exudate, lymph nodes, fever is there, patient is looking sick, go ahead. Sinusitis, hallmark is, you have post-nasal drip. Earache, persistent pain for about 24 hours, 48 hours, again, this may suggest bacterial infection, but right in the beginning, you don't have to prescribe antibiotics for this. I think if today there were not many questions about this. There is a post-test link in the chat box. Kindly attempt those, and I hope you got answers to your question during the presentation, and we hope to see changes in the scores here. Another take home, Gold 24 guidelines recommend triple drug therapy, glycopyrrolate, formoterol, budesonide. Is it rational? Yes. Sir, can you elaborate on this? Gold
Yes,
24.
Latest guidelines have come and they have recommended these triple combination drugs.
This is for COPD.
COPD. This for COPD.
Okay, post-test link is there in the chat box. Kindly go ahead and fill up. Only those who do post-test and have done both pre and post will be eligible for a certificate.
Thank you, sir. Thank you, sir, for your valuable time and
Thank you.
sharing in knowledge, like
I
valuable
think
knowledge to all the participants. Thank you, ma'am, for your immense support and making this session so successful. Dear participants, we have already posted the post-test link in the chat box. Also, we are sharing the YouTube link. This session will be available on YouTube after 4 days, and also feedback link will be shared. Kindly give your valuable feedback so that we can make it better. The next session will be on pain management in terminal care. It will be on 20th Jan 2024. Thank you, ma'am. Over to you.
kindly feedback जरूर provide करिए because that helps us to understand your needs. So if you don't give us feedback, then we won't know. There is no other way to know what are your requirements. Thank you, sir, for
thank you, ma'am.
coming over and sparing your Saturday evening with us.
Thank you, ma'am. Thank you.
Thank you.
Thank you, ma'am. Ma'am, I'll continue with the post test and then.
हाँ ठीक है thank
Okay,
you.
thank you so much, ma'am. Happy New Year.
हेलो। हाँ हो गया। अपनी मैडम को बोल दिया मैंने कि मैं छुट्टी लूंगी कल। आज भी छुट्टी है, कल भी छुट्टी लूंगी, ठीक है? कहाँ जा रहे हो? इसको गोली देनी है?